objectives are to discuss what is Parkinson's, review some characteristics that you've already heard about this morning from some of the great lectures that were done, discuss how to assess visual midline shifts and how posture, gait are affected, describe a systematic method to help determine starting Yoked Prism prescriptions to center the visual midline, and then to go over a case review. And you all have these slides that were in the handouts or online that you can download. So many of you, I have heard, have already read the article that was published in Optometry and Visual Performance this past April. So if you need to go back to it, pull it up. Hopefully that you're on the COVD listserv and it's on there. And I hope this discussion will give you some good pointers of what you can utilize back in your practices. So what is Parkinson's? So we know it's the second most common neurodegenerative disorder following Alzheimer's disease. It affects the basal ganglia. Specifically, there is a loss of nigrostriatal dopaminergic producing neurons, which leads to difficulty initiating movements and to slowing of movements. In recent research and with recent treatments, we are also discovering a lot of more non-motor symptoms that can affect these individuals. And so these include cognitive dysfunction, dementia, depression, pain, and fatigue. Another aspect of Parkinson's to remember is that it's variable. It's not a degenerative disease that runs its natural course. Oh, thank you. Awesome. Thank you. Okay. Thank you, Bill. So it's not typical. If someone were to be diagnosed with Parkinson's at age 60, they will be in a wheelchair by age 70. So there's no distinct progression. It is extremely variable, where someone can have Parkinson's for 20 to 30 years with almost no limitations, whereas others will have it for 5 to 10 years and have significant disability. So our job is to work towards achieving our patients' goals and knowing exactly how Parkinson's is affecting them and what do they want to gain by seeing us. Epidemiology. Men are a little bit more prone to be affected than women, although newer studies are suggesting no difference. Individuals of all ethnic groups are affected, although again there are newer studies that suggest there may be higher and lower prevalence rates amongst different groups. Mean age of onset is usually early mid-60s, but there has been a recent surge of young onset Parkinson's. Reported cases 5 to 10%, but possibly higher, where the age of diagnosis is between 21 and 40. So the essence of Parkinson's is a dopamine issue. The dopamine-producing cells in the substantia nigra are at fault. Dopamine is not there to modulate the motor cortex, to give the information to the muscles for movement control. If dopamine is produced, the substantia nigra neurons transmit information in order to affect direct and indirect loops for motor control. When there is an inadequate dopamine, movement itself and speed of movement are affected. So characteristics, these were exactly the same order in the earlier presentation, so awesome. Rigidity, slowness of movement, which is bradykinesia, the stooped posturing, and then postural instability. Another common symptom is tremors that are more prominent with rest. Pill rolling is common with the fingers. Characteristics that the caregivers will report will include when they write, their print is very small and it shows a gradual fade. When asked to walk, the Parkinson's patient will exhibit a reduced arm swing, stride length and speed. They'll have that shuffling gait. Their speech will be soft and lack volume. Visual things that we'll notice will include poor low contrast visual acuity, poor color discrimination, an abnormal blink reflex, abnormal pupil reactivity with anisocoria, hypometric saccades, smooth pursuit abnormalities, and then if you have visual evoked potentials, you're going to see increased latencies of the P100. So diagnosing Parkinson's is not easy and can take considerable time. And again, there's not one specific test available that really confirms diagnosis at this point. So when a patient consults a Parkinson's examiner, one critical component of the workup is the detailed neurological history. And during the evaluation, the patient will be asked to draw, write, walk, and speak. And then a brain scan may be suggested to help rule out other types of Parkinson-like disorders, but there is no scan available at this time to confirm a definitive diagnosis. Brain scans of these patients usually show no abnormalities. There is a newer type of brain imaging scan known as the dopamine transporter scan, or DAT-SPECT. Can help specialists determine if there is a loss of dopamine-containing cells. Unfortunately, an abnormal DAT-SPECT can also be found with other rare neurological disease processes, so it's not a definitive test for diagnosing Parkinson's. So let's get to the main reason why I'm here to give this lecture. Remember, it is common to see postural changes at some stage with the Parkinson's patient. The different types of deformities with their medical name includes camptocormia, that's that stoop posture due to marked bending at the thoracolumbar spine, the anticollis, which is the dropped head, and then lateral flexion, which is called Pisa syndrome in the Parkinson's world, but as we know it, visual midline shift syndrome.